Good afternoon, everyone, and welcome to today's webinar, Infant Safe Sleep, an Introduction and Model Program. This webinar is being sponsored by the Children's Safety Network. My name is Abby Collier, and I am the Director of the National Center for Fatality Review and Prevention, and I'm thrilled to be with you today. I'm also honored to be a part of the Children's Safety Network Now Alliance. Children's Safety Network is funded by the Health Resources and Services Administration of the U.S. Department of Human Services. Before I introduce our two speakers, my colleague Rebecca Wilmer has a few technical announcements. Rebecca?
All right, thanks, Abby. So audio is currently being broadcast through your computer speakers, and if the quality of the audio depends on the speed of your internet connection, so if the audio is choppy, please find a more stable internet connection, or you can listen over the phone by dialing 866-835-7973. If you are listening through the phone, please mute your computer speakers to eliminate any echo. Phone lines will be muted during the presentation to eliminate any background noise. Answers to frequently asked questions are in the webinar instructions pod that you can find in the upper left-hand corner. And if you have questions or technical issues, you can type them into the Q&A box that's on the bottom left at any point, and we will pause for the presenters to answer your questions after the presentation. We also have a PDF of the slides available to download right above the slide deck. You can click on PDF of the slides and then select the Download Files button to save the document to your computer. This webinar will be recorded, and the archive will be sent out to all registrants within 2 weeks. All right, back to you, Abby.
Thanks, Rebecca. It is my honor today to introduce our speakers. Our first speaker, Sharyn Parks Brown, is an epidemiologist with a background in mortality surveillance as well as maternal child health research. She's currently a senior epidemiologist and data manager for the Sudden Unexplained Infant Death and Sudden Death in the Young Case Registry program in the Division of Reproductive Health at the Centers for Disease Control and Prevention's National Center for Chronic Disease Prevention and Health Promotion. Dr. Parks Brown is also a commander in the U.S. Public Health Service with more than 10 years of service. During her accomplished career, she has also been a senior scientist with the National Violent Death Reporting System, as well as a co-lead for an adverse childhood experiences study. After Dr. Parks Brown, we will welcome Cherie Sage, who is the State Director of Safe Kids Kansas. She's worked in injury prevention for more than 20 years and spending the last 16 of those years with the Safe Kids Coalition. She holds a master's degree in management from Baker University and is a graduate of Kansas Public Health Leadership Institute and is a child passenger safety technician instructor. Joining Cherie will be Christy Schunn, who is the Executive Director of the Kansas Infant Death and SUID Network. Christy is licensed by the state of Kansas as a clinical social worker. Christy has worked with bereaved parents and families as a hospital and hospice social worker within the foster care setting and as an adjunct instructor at Bethel College in the social work department from 2014 to 2018. Most recently, Christy provided technical assistance to statewide fetal infant mortality review programs and has worked with the Kansas Department of Health and Environment to embed safe sleep in prenatal education programs, child care licensing, and home visitation programs. We have an exciting lineup of speakers today, and please join me in welcoming our first speaker, Dr. Sharyn Parks Brown.
Can you hear me?
Yes, you can.
Yes.
Great, thank you. Thank you for the introduction, Abby. Good afternoon, and I want to start by thanking the Children's Safety Network for the invitation to speak with you today. Before I get started, I do have to share our standard CDC disclaimer that my presentation represents my views and are not an official position of the CDC. So what I would like to do with this first part of the webinar today is to really set the stage before we hear from our colleagues in Kansas about some exciting safe sleep work that they're doing. So I'm going to be talking about sudden unexpected infant death. So I will start by defining sudden unexpected infant death, which I'll refer to as SUID. I'll review some data specifically on the epidemiology and trends. I'll talk about CDC's role in addressing SUID and then provide an overview of some available sources on data for SUID. So beginning with the definition of SUID, it is the unexpected death of an infant under 1 year old in which the cause was not obvious before an investigation. There are about 3,500 of these in the United States each year. They often occur during sleep or in a baby's sleep area, so we often refer to these as sleep-related infant deaths. This includes deaths due to sudden infant death syndrome, or SIDS, other undetermined causes, and then also accidental suffocation and strangulation in bed. So now I'd like to talk a little bit about what we know about the risk and protective factors for SUID. We don't know the cause of many of these deaths, but research has provided some insight into the risk factors. Much of the risk factor research has been focused on SIDS, but from what we know, the risk factors for all types of SUID are similar. So the things that we know increase the risk are non-supine, so that means stomach or side sleep position, sharing a sleep surface with another person, using a non-firm sleep surface, such as an adult bed, use of soft bedding in an infant's sleep area, so that includes things like bumpers, comforters, blankets, pillows, even stuffed animals. Also letting an infant get too hot while they're sleeping due to either room temperature and or excessive clothing also increases the risk. Prenatal use of alcohol or tobacco and exposure to environmental tobacco, or being in the care of an adult who's under the influence of alcohol, are also known to increase the risks. So this means that to reduce the risk for every sleep, so that's at night and for naps, infants should be placed on their backs, on a separate sleep surface, preferably in the same room with their caregiver. The surface should be firm, flat, and level, so something like a crib, portable crib, or bassinet with a tight-fitted sheet. It should be free of thick blankets or other soft bedding, so all of the objects I mentioned just a moment ago. And the baby should be kept cool, so dressed in no more than one layer more than an adult would be comfortable wearing in that environment. And then we also recommend that women stop smoking during and after pregnancy, and that parents not allow anyone to smoke around their infants. And women should avoid alcohol use during pregnancy, and also avoid having infants in the care of anyone who's under the influence of alcohol. So you might wonder, how common are some of these risk behaviors? Some recent estimates are that more than 75% of infants in the United States are placed to sleep on unsafe surfaces. More than 60% at least occasionally share a sleep surface with at least one other person, sometimes multiple people. About 40% are sleeping with soft objects in their sleep environment. Some smaller but still significant numbers are being placed to sleep on their sides or tummies and are being exposed to tobacco and alcohol in utero. So we do still have some work to do with addressing these risk factors. In addition to the risk factors, we know that there are some things that have been shown to be protective, including breastfeeding and pacifier use. It's estimated that 60% of new moms are breastfeeding at least through the infant's first 2 months. And then one population-based study showed that 32% of infants were being put down to sleep with a pacifier. So the prevalence of these protective factors is encouraging, but there's still certainly some room to improve. So now I'm going to transition and talk a little bit about our understanding of the epidemiology and trends of sleep-related infant death, or SUID. So this first graph here is showing recent U.S. data, and it demonstrates that the peak age of these deaths is between 1 and 2 months, and the majority of them occur before infants are 5 months old. And here I'm showing the rates for all SUID from 1990 to 2016. And you can see that in the early 1990s, there was a pretty steep decline in the rate of SUID in the United States. The decreases accelerated around 1992, which is when the American Academy of Pediatrics initially recommended infants be placed on their backs to sleep. And then also followed shortly thereafter by the National Institutes of Health launching their Back to Sleep campaign in 1994. But around the late 1990s, the decreases in the rates had really slowed, and the rates have remained relatively stable since around the year 2000. So these data really support the importance of infants being placed on their backs to sleep. So here you can see that as the percent of mothers who reported placing their babies to sleep on their backs increased, which is in the orange line, the number of deaths decreased. And then as that percent leveled off, unfortunately, so did the rates of death. So this is an area where increased awareness and efforts to improve the knowledge and capacity for families to implement safe sleep practices that we're going to hear about from our Kansas colleagues in a few minutes could have an impact. From this map of the United States, you can see that there's a lot of variation in the rates of SUID among states. So based on data from 2013 to 2015, the state-specific rates of SUID ranged from 33 per 100,000 live births in Vermont to over 200 per 100,000 live births in Alaska. We also see stark differences in these deaths based on race and ethnicity. So American and Indian, Alaska Natives, and non-Hispanic blacks have the highest rates of SUID. And the rates for both of those groups are more than twice as high as those for non-Hispanic whites, shown in gray, and for the U.S. overall. We also consistently see the lowest rates among Hispanics and Asian Pacific Islanders. And even after we adjust for other factors, race remains a significant predictor of SUID. And when we look at trends, the patterns in these disparities has sadly remained pretty consistent over the last 20 years. Another thing I wanted to mention is that underlying the overall SUID rate, some important changes have been taking place with the epidemiology for SUID. So included here are the three subtypes of SUID, so SIDS, undetermined cause, and accidental suffocation. You can see that in 1990, the majority of these deaths were being classified as SIDS, so that's shown in the gold line. That number decreased sharply with the national uptake of supine sleep in the early 90s and then continued to fall, albeit more slowly after 2000. Also in the graph, you can see that the gradual fall in SIDS did not result in a corresponding decrease in the overall SUID rate shown in the blue line. So instead, the deaths classified as undetermined cause, shown in green, or accidental suffocation, shown in purple, increased. So the decreases in SIDS were being offset by almost equal increases in the other two types. So that leads you to wonder, why might that happen? So to understand this kind of shifting among the subtypes, you have to know a little bit about how deaths are investigated and certified in our country. So medical examiners and coroners are responsible for investigation into SUID, and they make the determination as to the cause of death in these cases. So depending on how they certify, the cause and manner determines how the deaths are coded in our National Vital Statistics System, which are the data that we typically use to study epi trends nationally, and those are the data that I've been presenting. So traditionally, these three causes shown on the previous slides are used to quantify SUID. But there's evidence that there's a shift within the medical examiner and coroner community, resulting in fewer of the deaths being certified as SIDS and more of them as either undetermined or accidental suffocation. And the reasons for that shifting, which we often refer to as diagnostic shifting, are complex and they're numerous, but includes improvements to investigation, so more thorough investigations into the circumstances surrounding these deaths has increased the recognition of the potential for suffocation. There's also increased influence of the multidisciplinary state and local child fatality review process, and then also influencing this is death certifiers' preference to not use SIDS. So all of this is impacting our ability to conduct surveillance on SUID and research, and it's also inhibiting our understanding of the true causes of these deaths and ultimately our ability to effectively prevent them. So now I'll talk a little bit about what CDC is doing to address SUID. First of all, to help increase our understanding of the true burden and factors associated with sleep-related infant deaths in SUID, we support the Sudden Unexpected Infant Death Case Registry, which is a multi-jurisdictional population-based surveillance system. The goals of that system are to conduct population-based surveillance, categorize the SUID cases using a standardized algorithm that we've created, then use those categories to monitor the trends and describe demographic, environmental factors that play into the deaths. We also provide information that will help improve death scene investigations further, and then ultimately use our data to inform prevention activities and reduce infant death rates. Our surveillance system is currently operating in 22 sites, and we cover about 30% of all the SUID in the United States. In terms of the program model, it was in close partnership with the National Center for Fatality Review and Prevention. We built the case registry upon the established death review programs in our participating jurisdictions, and we rely upon the National Center's web-based reporting system and protocols, as well as their established multidisciplinary review of medical, legal, and other records to glean information on SUID cases and several domains, including demographics, infants' health history, details about the infant's sleep location and position, and then other details about their sleep environment. So as I mentioned, one of the goals of the registry is to categorize SUID cases using a standardized algorithm. So we created our SUID classification algorithm so that we could have a standardized grouping method and more consistently monitor SUID. We also wanted to be able to account for unknown and incomplete investigation information so that we could inform improvements to case investigation processes. We wanted to be able to acknowledge the uncertainty about how suffocation may or may not have contributed to each death, and also to allow us to calculate population-based incident for each type of SUID based on our standard groupings. And ultimately, this will allow us to have more consistent comparisons of the different types of sleep-related infant deaths. So our case registry awardees are applying this classification system and algorithm during their child death review meetings. And through group consensus process, all of the available data on each case is reviewed using our algorithm's definitions, and the cases are assigned to the most appropriate of the 7 mutually exclusive categories I'm showing here. And then in addition, each case that's either assigned to explain suffocation or possible suffocation are also assigned a mechanism, and the possible mechanisms of suffocation are soft bedding, overlay, wedging, or other. And just to quickly give you an idea of what this looks like, I'm showing data here from the first 5 years of case registry data that we've classified using our algorithm. The most common category for these cases is unsafe sleep factors. About 1/4 of them end up categorized as having incomplete case information. About 15% are assigned to either possible suffocation or explained suffocation. Only 2% were found to have not had an autopsy or death scene investigation, and then only 1% are categorized as having no unsafe sleep factors. So as a result of using this classification system, we're hoping that our child death review programs that are participating in the registry or otherwise using our classification system will be able to more accurately and consistently track SUID, including the different subtypes over time, and be able to compare across states and jurisdictions. We also hope that use of the algorithm will be able to help identify gaps in SUID investigation and reporting, so informing where we can further improve death scene investigation and autopsy practices. And then also by looking at differences within each SUID category, we hope our awardees can more easily identify the highest risk groups to target for intervention and other services. An additional effort at CDC is our maintenance of the Sudden Unexplained Infant Death Investigation Reporting Form, which we also refer to as the SUIDRF. I've got a screenshot of that here. The SUID quickly is an 8-page form that allows death investigators, to record a lot of details on the investigation of each case. So this includes a witness interview, infant's detailed medical history, mom's pregnancy history. It includes an investigation summary, diagrams, a summary report to be provided to a pathologist, and then a lot of detailed incident scene investigations. So looking at where the infant was last placed, last known alive, how the infant's body was found, contents of the sleep environment, and whether a doll reenactment was performed. So all of that information is actually used in a variety of ways. It's obviously used during the death investigation, but it can also be used to assist in determining the cause of death. So the detailed description of an infant's airways and sleep environment, for example, can help medical examiners and coroners distinguish between unexplained and explained causes of death. The information from the SUID is also used a lot during child death review meetings. So the information from the form is actually entered into the National Fatality Review Case Reporting System with the purpose of helping inform development of prevention activities. So in addition to the SUID Case Registry and maintaining the SUID, there are several additional efforts underway at CDC. As of 2016, 4 questions related to infant safe sleep are now being asked of all respondents of the Pregnancy Risk Assessment Monitoring System, also known as PRAMS. So that is going to help us better estimate the national prevalence of infant safe sleep factors, to identify population at risk for unsafe sleep factors, and then hopefully help improve safe sleep practices ultimately. We promote the American Academy of Pediatrics Safe Sleep Recommendations heavily, and as well as NIH's Safe to Sleep campaign, and we encourage adherence to these recommendations by our 22 case registry awardees as well. And then I also wanted to mention we at CDC in our Division of Reproductive Health indirectly support a number of hospital-based quality improvement efforts related to infant safe sleep through our perinatal quality collaboratives and our national network of PQCs. Aside from SUID Case Registry and PRAMS data, to talk a little bit about other sources of data, there are a couple ones I wanted to mention quickly. Available from our CDC colleagues at the National Center for Health Statistics. They have vital statistics data files, which are downloadable, and they contain data on from birth and or death certificates. They're huge data files which require use of a statistical software package like SAS or Stata to analyze, but they are a source of a wealth of data and are excellent sources for nationally representative data. NCHS also maintains a web-based data query system called CDC Wonder. I've got a screenshot of that here, which allows you to build your own customized queries of vital statistics data sets. So this is a great tool for obtaining national, state, and even county level stats on various causes of death, including SUID and the subtypes. And it allows you to look at data by year and broken down by a variety of geographic and demographic variables, including maternal characteristics. And then last but not least, I wanted to put in a plug for child death review data available through the National Center for Fatality Review and Prevention. So while each user of NCFRP's web-based system retains ownership of their data, the National Center has created a data dissemination process through which anybody can request de-identified data sets for analysis. So all of the variables that populate our SUID case registry are included in NCFRP's database and therefore available through their centralized data request process. So more information on that is available from NCFRP's website, which is shown here. And with that, I want to thank my colleagues here at CDC, our colleagues at the National Center, as well as all of our SUID case registry awardees. And now I can turn it over to our colleagues from Kansas.
Great, thank you, Dr. Brown. So, hello, I'm Cherie Sage. I'm the State Coordinator for Safe Kids Kansas, and we are happy to be joining you today to share our efforts in Kansas over the past several years to reduce infant mortality from unsafe sleep practices. And I'm joined today by Christy Schunn from the Kansas Infant Death and SIDS Network, also known as the KIDS Network. And this organization has been really central to our efforts in Kansas, and Christy will be sharing more about this in just a moment. I'll just provide a brief background for you. Our state Safe Kids Coalition was founded in 1991, and our lead agency is the Kansas Department of Health and Environment. And our coalition established a 501c3 back in 2003, which increased our capacity to receive grants and charitable contributions, which is particularly helpful as we look for streams of funding to provide items such as portable cribs to our low-income families. Now, our state coalition includes 70 statewide partners, as well as a network of local Safe Kids coalitions across the state. We currently have 27 local coalitions covering 32 of our state's 105 counties. This means actually approximately 69% of Kansas children have a Safe Kids coalition serving their county or community, as our presence actually tends to be in the areas where we have a greater population density. So I point this out mainly because these coalitions are part of our strategy to reach families with education and resources. So as we share with you our safe sleep efforts in Kansas, I'm going to start with just a little history, starting with a project that took root 10 years ago and is actually still being used today. So back in 2010, the KIDS Network, Safe Kids Douglas County, one of those local coalitions, and several other partners from sectors that include hospitals, education, child care, and university research, they identified the need for an updated educational tool with current information that would provide a simple, clear message to parents about safe sleep. So these partners collaborated to create a video that could be used by hospitals, particularly with discharge education for new parents, and health departments and home visitation programs so they could educate families on best practices for safe sleep. So we ensured that we had diversity in the filming, and we used real families. I think that lent some real authenticity to the messaging. And the video was then distributed statewide in a DVD format along with an informational booklet to accompany each video. Now, these were distributed at that time to all the birthing hospitals and health departments across the state. We also created a website where we could post multiple versions of the video in both English and Spanish, in both high and low resolution, and it included resources such as a link to the Consumer Product Safety Commission recall list. And the website really helped us to increase our reach, and the video is still being actively used in Kansas as well as by other states today. You can see it here, safesleepkansas.org. So data is integral to this work. Our time and resources are limited, so we have to be strategic in how we address preventable injury and death. So every 3 years, Safe Kids Kansas compiles a data report looking at causes and rates of unintentional injury and injury-related death of Kansas children ages 0 to 19. So the report includes emergency department, hospital discharge and mortality data by risk area, and is available on our coalition website, safekidskansas.org. And in 2012, the coalition decided to use this information to focus greater effort on specific injury risk areas based upon this data, and we established 4 target priority areas. Suffocation is the leading cause of infant death in Kansas, and most of these occur in the home and are a result of unsafe sleeping environments. Safe sleep easily became one of our 4 priority areas, and a work group was formed. Now, there were several partners already doing work in the safe sleep arena, so really the purpose of the formation of this group was simply to strengthen the collaboration and the communication and support among these partners and to explore additional opportunities for greater reach and impact. This Safe Sleep Work Group continues to meet bi-monthly and is chaired by a subject matter expert, which is my colleague, Christy Schunn. One of the first tasks of the Safe Sleep work group was to get the lay of the land. We needed to gather information on current practices and policies and staff knowledge in the birthing hospitals across the state. We created a survey which was disseminated by our partner, the Kansas Hospital Association. So Christy will now share a little bit more about the survey results and how this information helped to launch our current efforts. So Christy?
Thank you, Cherie. I, too, am grateful to the CDC and the Children's Safety Network for inviting us to share a little bit about what we're doing here in Kansas. And like Abby said and Cherie said, my name is Christy Schunn. I'm the director of the Kansas Infant Death and SIDS Network. The Kids Network is a statewide private 501c3 that began just about a little over 20 years ago. And it was initiated by a group of bereaved grandparents, parents, and community members. Originally, we were the SIDS Network of Kansas, but rebranded in 2013 to become the Kids Network so that we could better serve different types of infant deaths, including these SUID deaths, SIDS, ASSB, but also congenital anomalies, stillbirth, and miscarriage. And so our overarching mission is to provide bereavement support to families that have had an infant die for any of those reasons. We also provide community education and the research to reduce infant death. So I wanted to begin with a quick look at Kansas infant mortality. Our infant mortality categories break down much like the rest of the United States. The leading cause is congenital anomalies, things like neural tube defects like spina bifida, anencephaly. The second leading cause is prematurity or low birth weight, which is over in that red pie shape. And then the third leading cause is sudden unexpected infant death. Again, those SIDS, asphyxia, suffocation, strangulation in bed, or ASSB, and some of the unexplained that Sharyn talked about earlier. So we know that these SUID deaths are the third leading cause of infant death. And I always point out that this orange piece that ends up being bigger is really rare diseases like necrotizing enterocolitis, car accidents, et cetera, so that makes a bigger chunk. But these three on the right side of the pie are what we're really trying to work on, and then very specifically what we're talking about today are these SUID deaths. So I'll go back to the online survey that Cherie was just talking about. What we learned was that we needed to research, what was already being done. So the Kids Network and Safe Kids Kansas teamed up to work on these sleep-related deaths. We quickly expanded that collaboration to include a number of entities that are so long that it would be almost impossible to say here, but very specifically you'll see at the top CRIBS, which is the Center for Research in Infant Birth and Survival, and that's our external evaluator through the University of Kansas, and then obviously the Kids Network and Safe Kids, but we've had different funding sources come in from our Children's Initiative Fund, and I'll talk a little bit more about March of Dimes and the Kansas Department of Health and Environment as some of our strong partners. So to do this online survey, we partnered with the Kansas Hospital Association to route the online survey to just assess the current safe sleep practices and policies within our birthing hospitals. And our results were 31 of the 73 contacted hospitals responded, about 42%. Individual survey respondents represented various hospital departments, so including in there were newborn, well baby at 68%, some non-nursery at 29%, and the NICUs, or the neonatal intensive care units, about 3% of those reporting. 58% stated that they had been trained on safe sleep. 44% held annual safe sleep training in their entity. 39% had a safe sleep policy in their structure, but only about 33% audited compliance with that policy. And that's the kind of situation where, we know in this hospital we always put babies on their backs to sleep, but do we have somebody that's going through and auditing that? We knew that that was something that we needed to think about. So in conclusion, what we learned from the survey is that the top barrier to sleep or to safe sleep was reported as conflicting patient-family beliefs. So we were putting babies on their backs to sleep, we were educating, but we were dealing with pushback from the family members in many cases, as reported on this survey. We learned that there needed to be assistance with the auditing of the policies. We knew that there needed to be better access to sleep and safe sleep materials. And we also learned that we need to make sure that the hospital is not solely responsible for safe sleep education, that there's a much bigger continuum. So this survey led us to the creation of a safe sleep toolkit for hospitals with sample policies, working with outpatient communities and larger community members. So we developed this continuum. So our strategy is to do a consistent safe sleep message. So we are working currently to build this comprehensive strategy to implement consistent safe sleep messages from preconception through the first year. And we know that there needs to be consistent doses across the continuum. Originally, we were spending a lot of time after the baby was born, kind of in that first year. The American Academy of Pediatrics, they had the safe sleep recommendations. But we've always said, we need to back this up, and everyone said you need to talk to the hospitals. And so we were going to the birth centers and the hospitals and educating about safe sleep. And I've been training groups of nurses for years, and they would say, well, we have about 24 to 48 hours. Hospital birthing centers are sort of like a drive-through. We really need to back this up and work in clinical care and prenatal education and the home visits. And we just kept figuring we should probably back all the way up, and we need to really be educating family and friends, the whole community, health classes. And I often, joke around with folks that we really need to be educating, our young kids. Some of our best voices are kindergarten first graders that are learning about safe sleep, not because they necessarily are planning to have any children anytime soon, but they might have siblings. They may be able to carry that message home. So our consistent safe sleep messages go across this continuum of care. And so we've built all of this based on that survey as one of the pieces, and with the work of our external evaluator, constantly learning what we need to do to get better at what we're doing to make sure that we're embedding the safe sleep message across the community. Some of the national evidence is that inform safe sleep strategies that are happening and working in different areas. The national experts compiled all of those following approaches. One of them is safe sleep community baby showers, and I'll talk a little bit more about that in a minute. Crib distribution programs are seen as, the national experts have identified that these are evidence-based safe sleep interventions. These are things like crib clinics, the Hospital Cribs for Kids program. A BAM collaboration is originally through the March of Dimes. They were called Becoming a Mom, making sure that new moms have access to that information, and then the home visiting programs. We also know that child care legislation is evidence-based, that we know we reduce or increase safe sleep if the child care providers are trained and licensed to do such. And now this new 60-day mobile health program that actually has been just gotten off the ground with Dr. Moon, who's listed as the the lead author of the article that came through the current pediatric review. Dr. Hauk, Dr. Colson, Dr. Moon have worked on a 60-day mobile health program that just rolled out the beginning of this year. So we're looking more into that as the days unfold. So this is what we knew was working, and we needed to know how we would add to this. So the collaboration of us got together to build a statewide infrastructure to enhance our capacity to share these consistent messages with providers, parents, and caregivers. And we started with a pilot project to test the idea of the Safe Sleep Instructor idea, and we partnered with the March of Dimes and got some of our just initial funding from MOD. We provided safe sleep training to a group of professionals who in turn went and trained at least 10 professionals in their home community or in their own structure, whether that ended up being a health department, a hospital, a child care facility. After we did that initial pilot, we learned that we needed to expand this, and so we wrote a grant to the Kansas Department of Health and the Kansas Department of Health and Environment for Title V MCH, and we were awarded that funding several years ago, and we started the Safe Sleep Instructor certification process. And so our hope was to find champions or influencers in communities across the state that could deliver the safe sleep message. And along with that, they are learning to not only train people in their home communities, but also facilitate a Safe Sleep community baby shower, implement a Cribs for Kids hospital Safe Sleep certification program in their local delivering hospital, and implement a Safe Sleep Start outpatient toolkit in their OB clinic, their pediatric clinic, and their family medicine clinic, if they have all of those or any one of those, depending upon the size of the community. So this project is to train champions across the state that can then drill down and deliver the Safe Sleep message at a variety of levels. The Safe Sleep, one of the lessons that we learned is that the Safe Sleep instructors needed to be able to identify a different level of certification for themselves. So the certified Safe Sleep instructor can choose to be certified at one of these 3 levels. The highest level is Gold, and what they agree to do once they're trained is train at least 10 professionals or caregivers in their home community. And we have pre-test and post-test that we're gathering to figure out if there's an education change or a knowledge change. They also agree to host a community baby shower or a crib clinic, and I'll talk a little bit more about that in a few minutes. They agree to connect with their local delivering hospital to get the hospital certified to be a Safe Sleep hospital. And they also agree to work on the Safe Sleep Start outpatient toolkit with one of their outpatient practices, again, whether that's pediatric, family medicine, or OB. So some of our champions decided to be the Gold level. Some decided that they were not able to do all 4 of those things, and so they wanted to be a Silver level. And so they train 10 professionals, they do a baby shower crib clinic, and then they can choose to do the hospital certification or the outpatient toolkit. And then the Bronze level is, I can't do the hospital or outpatient, but I am able to train at least 10 people, and I am able to do a community baby shower or a crib clinic. So the champion self-identifies at what level they want to be certified. So the trainer results. So far, since we started this project about 4 years ago, we have trained 115 healthcare providers, home visitors, or early childhood professionals. They come together for a 2-day training, and the highlighted counties, like Cherie said, we have 105 counties in the state of Kansas, and so there's 40-plus counties there that are highlighted in yellow where we have champions. And some of our larger communities might have more than one Safe Sleep instructor in there, and we encourage those Safe Sleep instructors in that community to team up and work together on different things. So we've pulled these 115 people together. Each training, averages in size. We started with 25, and this last year we had almost 90 people in the room. So they come for a 2-day training, and they learn through demonstration, breakout sessions, and they practice with feedback. So we're having them get up and present information. We're having them get up and do crib clinics. We also have instructors not only from Kansas, but we've had a few instructors come from Nebraska, Pennsylvania, and Michigan. When they heard about this program, they were charged with doing Safe Sleep in their home state, in their home communities, and they wanted this information. So we have a couple of states that have jumped on board at this point. What we know from doing this train-the-trainer with all of the champions is that the instructors significantly increase their knowledge from pre-test to post-test. So one of the things that I say in all of the things that we're working on, we are trying to figure out what did they know and do they know more now. So the instructor-led training, the SSIs provide training to at least 10 people. The results are 54 Safe Sleep instructors trained another group of people. Those trainees significantly increased their knowledge from pre-test to post-test. There's 12 questions. On pre-test, they were 8.9 and increased to 10.2. They also learned to do a community baby shower, and these community baby showers basically are there to educate people that are maybe falling through the gaps. Maybe they don't have access to the hospital, labor delivery, or OB. And so originally we targeted the African American expectant woman and her support person to come into a baby shower. we are looking for those folks who maybe fall in the gap that don't have insurance, maybe got late prenatal care or delivering in the ER. We've partnered with the Black Nurse Association to deliver the culturally appropriate messages. And so when the women come into the baby shower, they are trained on a variety of things. In 2018, we had 29 showers. There were 870 pregnant women who participated in the pre and post test, and you can see there that there's a variety of ethnicities that are represented. Also our high-risk population, those that have less than a high school diploma, and we have a special shower that's running simultaneously that is for Spanish-speaking folks only. So we've broken those showers into two. And our results on the showers, this is kind of a busy slide, but basically we're looking at educating on three main things, and then we add to that. But we know that a lot of these women are, 7, 8 months pregnant. We want them to go home with safe sleep information. And we don't want them to just have knowledge, but we want to have an intention to practice safe sleep. So we have in FY18, all of the participants significantly increased their knowledge and intention to not only practice safe sleep, but also to breastfeed. And we want them to know their resources. So are you confident to breastfeed? And can you identify at least 3 local resources to help with breastfeeding? And then tobacco cessation the same way. Do you have ways to avoid secondhand smoke? And if you yourself want to quit, do you know at least 3 local resources? So about 10 or 11% of our participants say that they use tobacco, and about 40% want to quit in the next 30 days. The Cribs for Kids hospital certification, we really didn't create anything new. We went to Cribs for Kids, which is a national organization, and they have 3 requirements or 3 different levels, bronze, silver, and gold, and that is to have the hospital do a safe sleep policy, educate their parents, replace blankets, get involved in the community, and be a partner of Cribs for Kids. And thus far, we have 2 bronze hospitals and 4 gold hospitals in the state of Kansas. And then the Safe Sleep Star Outpatient Toolkit is kind of under the same heading, and that is we have bronze, silver, and gold. And if a clinic agrees to become a safe sleep clinic, they need to provide annual safe sleep training to their staff. They need to have a policy that they will always practice and educate about safe sleep. They need to distribute materials to their clients. If they become a silver level clinic, they need to do a safe sleep quiz, which is basically a quick 4-question location, position, environment, tell everybody about safe sleep, and then we again collect pre and post test data to figure out if that mechanism is successful. And then lastly, the gold level is that we would have the safe sleep education and the hospital, or I'm sorry, the clinic involved in baby showers, health fair, things within their community, so to have a very consistent message across the board. Some of our next steps are to continue to prioritize our communities with high infant mortality rates. We need to engage more community members, so like the Wichita Black Nurse Association has been integral in this process, and we are trying to bridge that and build that across the state. We want to embed the Today's Baby in the SSI infrastructure, and that's that 60-day mobile app. And we also want to engage more of the first responders, and that's really where Safe Kids has come in. They have a lot of EMTs, firefighters, law enforcement, and so bringing those first responders into the safe sleep messages. So I will just say in closing that our 2019 annual Safe Sleep Instructor Training will be mid-September, September 12 and 13, where we will pull new Safe Sleep instructors together to do this 2-day training to teach them to do the training itself, the train the trainer, also the baby shower, the outpatient toolkit, and the hospital certification. So with that, I want to thank Cherie, move on to the next slide, and we'll wrap up and then take some time for questions. Cherie, back to you.
Thanks, Christy. You can see our contact information here on the screen and our website, so we are happy to have you reach out to us, and we can give you more detail on what we shared with you today.
Great. Thank you to all of our presenters. Such wonderful information shared. As a reminder, you can enter your questions in the question pane. So we have a few questions already that we'll get started with. I think this first question I'm going to send your way, Sharyn. Could you explain the difference between SIDS and SUID?
So that's a good question. SUID we actually used as the kind of umbrella term to incorporate or encompass the three different types of deaths. So those that are called or deemed due to unknown causes, those that are due to SIDS, and those that are due to accidental suffocation and strangulation in bed. By definition, SIDS is deaths that for which the cause is not known after a complete and thorough investigation. So that's including an autopsy, detailed scene investigation, and review of the clinical history. That's what SIDS is defined as. But in practice, we have seen with the statistics over time that very similar deaths, two different deaths that have very similar clinical history, scene setup, and physical findings at autopsy can be, one could be called SIDS and another one could be called suffocation, kind of depending on certifier preference. So because of that, we at CDC typically look at all of these deaths collectively. So that's why we monitor the SUID statistics collectively for all three types, because often there's not a clinical or otherwise significant difference between deaths in those three different categories.
Thank you so much, Sharyn. Kansas, I think this question is for you. Can you talk about where you get the funding that supports your safe sleep efforts?
Well, this is Cherie. We get it from lots of different places. It is something that we have to continuously seek out. There is no, unfortunately, there's no one funder who has committed to providing us all the resources that we need. But we have had some governmental grants before, some through the Kansas Department of Health and Environment, but also quite a bit of it has actually come from foundations, everything from health foundations to Prairie Band Potawatomi Nation also provided a grant for cribs. So really, we're continuously having to seek out new sources. I wish I had an easy answer for you to just go to this organization and ask for money, but unfortunately, it's been a bit of a challenge. But we continue to seek out new funding and use this data and our success stories to show the need and that what we're doing is effective if these organizations are able to invest dollars to us. Christy, do you have anyone else to add to that?
I think you covered it. The other thing I would say is that with the Safe Sleep Instructor project that we have, when we have the instructors come and train them, we actually write grants with them. So we leave no rock unturned. We write every grant we can. And so then we in turn show them how to write grants to get their own project off the ground in their home community. So that's one of the things that we've just, with computers nowadays, we've done the intention so that people can just cut and paste and write different grants themselves. But we look for donations everywhere, whether it's a government grant, whether it's a foundational grant, whether it's a special event. We use all of that to work on our safe sleep efforts.
Great, thank you so much. Sharyn, this next question is for you. In jurisdictions that have a both FEMR and a child death review team, is it the child death review team that participates in the case registry?
Yes, we fund our jurisdictions through the child death review programs in our funded jurisdictions are our awardees.
I'll make a shameless plug for a new resource just developed by the National Center. We released it yesterday, and it's centered on collaboration between CDR and FEMR, and so even though CDR teams are the ones funded by the case registry, oftentimes there's collaboration there. Kansas, this question is for you. There's a a number of questions about being able to share some of the components of your work. So people are curious if you're able to share the survey that the full survey that you conducted, how they could become an instructor in some of your Safe Sleep classes. So is there a website or resource place people can go to learn more about your work?
Sure. I would have them go to, like Cherie said, Safe Sleep or Safe Kids Kansas, and there's a Safe Sleep website there. For the Safe Sleep instructor, I would have them go right to the kidsks.org. So there is an article on the hospital survey, and so you can look at that article, and if you want more of the survey questions, you could always email me. So edirector@kidsks.org, and I can get you the survey questions. So look up that article first, and then if you want more information, that is in the slide deck with the reference. And then if you're looking at the Safe Sleep Instructor training, interested in attending or what different pieces of that, any questions that you have, go to kidsks.org, and it actually, there's like 3 different pages that go over exactly what the Safe Sleep Instructor will learn. And then if you become a Safe Sleep Instructor, we will give you all of the materials to then roll that out in your community. Cherie, do you have anything to add to that?
I think that you wrapped that up pretty succinctly. So also, we have provided some of the birthing hospitals in other states that have said, hey, you know, we would like a copy of the ABCs of Safe Sleep, the video that was created. We are happy to do that. Some of them have said, hey, we need this burned as a hard copy DVD because we're, you know, just depending on what the situation is where they're putting this in. It might even be, you know, a health department that is running it on kind of a closed circuit a monitor that's in the waiting room. The nice thing about the website is that because of the access to the low and high resolution in the English and Spanish platforms just off of the website, is that some of our home visitors, as long as they have access to Wi-Fi, can bring an iPad to their home visits and show the video to the family there. So there are a lot of different options, but please feel free to go to that website, or as Christy said, kidsks.org, if you want more information about the training.
And I know there was a question in there if we've ever done the Safe Sleep Instructor training in other states, and we haven't at this point. I don't think that's out of the realm of possibilities. I think to start off with, though, I would absolutely invite you to come to Kansas, see our great state and some of the work that we're doing, and I think maybe in the future you might see that we're in other places. So if you have questions about that, you can also email me.
Great. I think this is a question for you, Sharyn, but I'm not 100% sure. It says on one of the statistics slides, it says 76% were not sleeping in a crib or bassinet. Was that of all infants or of those who died of a SUID?
That was of all infants in the PRAM sample. So it's not fully nationally representative. I can't remember the number of states that are participating in PRAMs, but it's a large proportion of the country that's participating in PRAMs, and that was 76% of moms reporting on their infants their usual sleep position or location.
Wonderful. Thank you, Sharyn. We have time for probably one more question, and I'm going to pose this question to all of our speakers, recognizing we have about a minute, so we'll keep our comments brief, but we're curious if there's been any long-term evaluation done to see what impact Safe Sleep is having, and what we're learning from parent engagement around this topic.
Who wants to
So I think the question, just in summary, is, you know, are you aware of any long-term evaluation going on about Safe Sleep?
We're obviously in Kansas involved, I mean, long-term is, 10, 15, 20 years. So we know that sleep position, there's a lot of research being done there. As far as the mechanism to teach safe sleep and to change the behavior, that's more recent. So we are currently really working on evaluation at this point to figure out if what we're doing is successful, and that's what we're looking at. We know it's more about behavior than it is just knowledge and intention. So we're trying to get to behavior. So we've kind of been that cutting edge. We've moved into promising. We're trying to make it best practice. But so there's a lot of robust evaluation going on. But to say, is this the best mechanism to educate people? We have hunches and we have some research, but we're still working in Kansas to figure out what works and what doesn't work. And we're asking families, and I think that's what we're keep going back to with like the community baby shower, is asking the people who are having new babies, what will change your behavior? What do you need from us? And so we're doing some of that research.
Wonderful. Thank you so much. Sharyn, I hate to cut you off, but we are out of time. Thank you so much, everyone, for attending today's webinar full of great information and engaging speakers. Please take a few moments to fill out the short evaluation that you see on your screen, and have a wonderful day.
Thank you.
Thank you.
The meeting is now over. All the participants have been disconnected.